Good morning, everyone, and welcome to our Friday morning program. I hope that everyone, at least here in the U.S., had a wonderful and very safe July 4th celebration. We are back on track and with our Friday morning schedule. And as I mentioned, the last time we were together in early June, we are now past the 100 mark in terms of these programs and working on the second 100 here. And our schedule is pretty well locked in for the rest of 2022. We do have one edition of a second tumor board that we are conducting in the month of August, and we'll send you information regarding that. It's really my pleasure to introduce an international expert in thyroid oncology, Dr. Rossella Elisei, who is an associate professor of endocrinology in the Department of Clinical and Experimental Medicine at the University of Pisa. Dr. Elisei is an active member of editorial boards of the journal Thyroid, the International Journal of Endocrine Oncology, and the European Journal of Endocrinology. She spent time as a postdoctoral assistant at UCLA and at the University of Cincinnati College of Medicine, and her research has been supported by numerous research grants from a variety of different funding agencies. She is the recipient of numerous awards in recognition of the quality and the importance of her research. And she also has served as principal investigator as a clinician scientist in several clinical trials evaluating different therapies for thyroid cancer. And so it is really a pleasure to introduce Dr. Elisei. And as always, we encourage you to send in your questions, and I will do my best to field those questions before we get to the end of the hour. So with that, Rossella, I'm going to turn over the platform to you.
Good morning, everybody, and thank you, Dr. Urken, for the nice word. I will share my screen and my slides. Okay. Okay, can you see them?
Yes, all slat. We're great.
Great. So I will talk today about the medullary thyroid cancer and the new therapies that we are managing in these last years. Okay, as everybody knows, medullary thyroid cancer is a thyroid cancer just because he is anatomically a thyroid cancer, but it is a neuroendocrine cancer deriving from the malignant transformation of parafollicular cells. Parafollicular cells, which are completely different from follicular, they have no dependence from TSH. They do not produce thyroid hormones, but they produce calcitonin, and they do not take up iodine. So the tumor is completely different from all the other thyroid tumors. The initial treatment of thyroid cancer, whatever is the dimension, whatever is the extension, is at least total thyroidectomy and central lymph node dissection. Then, according to the extension of the disease, the neck ultrasound found findings, also ipsilateral and or contralateral dissection of lymph nodes of the neck can be performed. Over the years, the outcome of patients with medullary thyroid cancer has a little bit changed. In this figure, you can see on your left a series of from Mayo Clinic data published in 1992 and collected in a very old series, followed for more than 33 years. You can see that patients with distant metastases at the time of diagnosis had a really poor prognosis with a survival rate of 25% after 5 years from the diagnosis. While nowadays, this is our series of the last 20 years, you can see that still patients with distant metastases have a worse prognosis respect to the others, but after 5 years, almost 65–70% of patients are still alive. But the most important thing that you can derive from these two slides is that while intrathyroidal tumors, both in the past and in the present, can have a long survival and can be even definitively cured, all the other patients are not. And metastatic and progressive medullary thyroid cancer are candidates for systemic therapies. Which therapies, which type of systemic therapies we have? In the past, several schemes of chemotherapy, external radiotherapy, long-acting somatostatin, radiotherapy with somatostatin analogs, radioimmunotherapies, and many other type of systemic therapies were tried. But frankly speaking, we obtained very poor and temporary results. Things started to change when the tyrosine kinase inhibitors arrived on the clinical scenario. Tyrosine kinase inhibitors are small molecules which are able to block the activity of tyrosine kinase receptors, which are frequently and very often activated in a altered manner and inducing the cell proliferation. So the tyrosine kinase inhibitors can block this activation and can stop the tumoral cell growth. Why they were important for medullary thyroid cancer? Because the pathogenesis of medullary thyroid cancer is related to the oncogenic activation of RET. RET is an oncogene which is normally expressed in the parafollicular cells, and physiologically it is activated by a series of ligands which are able to activate or deactivate the receptor. But when it is altered, it is constitutively activated and the intracellular signals are always present and cells start to proliferate and to transforming in a wrong manner. Which type of alteration, activating alteration we can have on this oncogene? We can have mutations, mainly point mutation or small deletions, insertions, the so-called Int'ls, which are the most common alteration of RET in medullary thyroid cancer. You can see here that germline mutations of RET are present in about 98% of hereditary medullary thyroid cancer, and somatic mutation can be present in almost 45% of sporadic medullary thyroid cancer. To be complete in the description of this oncogene, we have also to say that it can be altered with another type of mutation that is a rearrangement, a chromosomal rearrangement. But these type of alterations are present in papillary thyroid cancer, in about 20% of papillary thyroid cancer, and also in some non-small cell lung cancer. We will not talk about this type of alteration because they have never been found in medullary thyroid cancer. As I previously said, RET germline mutations were confirmed to be the alteration, the main alteration, the causative alteration in the hereditary form of medullary thyroid cancer. You know that medullary thyroid cancer can be involved in multiple endocrine neoplasia, different type of syndromes. And in this study, in which more than 470 families were analyzed, we could observe that the germline mutation of RET were present in the majority of families. But also sporadic medullary thyroid cancer, which indeed represent the majority of medullary thyroid cancer. More than 75% of medullary thyroid cancer are sporadic. And inside sporadic medullary thyroid cancer, a somatic RET mutation is present in about 45% of cases. If we concentrate our attention on advanced sporadic cases, those who require systemic therapies, the presence of RET mutation is even bigger, up to 86–87%. So RET mutation is RET is the perfect target for a precision medicine. And in fact, when the first drugs, the first tyrosine kinase inhibitors arrived in the clinical practice, still at the time of clinical trials, some of them, particularly those with an activity against RET oncogene, were tested on medullary thyroid cancer. However, I want just to show you that these drugs were anti-RET drugs, but at the same time, they were also antivascular endothelial growth factor receptor drugs. You can see here that they had an activity, a strong activity also against these receptors, and some of them also for other still tyrosine kinase receptors. So they are defined as multi-kinase inhibitors. Among all these drugs, two of them in particular reached the clinical phase 3. And these are the results of the two big international randomized study after which the two drugs were approved. The ZETA study for Vandetanib and the EXAM study for cabozantinib. You can see here on your left, patients treated with Vandetanib in red and those treated with the placebo in blue. And these are the progression-free survival curves. You can see that there is a big difference in the two groups of patients in favor of those treated with the drug. Similarly, for the EXAM study, in blue you have here patients treated with cabozantinib, in yellow patients treated with the placebo. And again, the difference in the progression-free survival was highly significant, and the drug showed a great activity on these tumors. This just for show you some of our cases. This is a huge liver metastasis treated with Vandetanib. You can see that after a few months of treatment, the lesion was widely reduced. It was not completely disappeared, and I have to say that we never see we never saw complete remissions, but we could observe great shrinkage of the tumor lesions. This is an example of a lymph node metastasis treated with cabozantinib. You can see before and after 6 months of treatment, the lesion was widely reduced, and at the same time, it changed because it became devascularized and the aspect was completely different from the same lesions in the beginning before the treatment. So nowadays, at least in Italy, but in many countries all over the world, we have 2 drugs that can be used for the treatment of advanced and progressive medullary thyroid cancer, Vandetanib and cabozantinib. Both of them are, as I said, multi-kinase inhibitors. The problem is related, the clinical problem is related to the side effects and their impact on patients' quality of life. Here are reported the most common adverse event of Vandetanib as reported in the ZETA trial. Here I indicate the adverse events that were more frequent, present in more than 30% of the patients. You can see diarrhea, you can see nausea, hypertension, fatigue, headache, acne, asthenia, vomiting. And if we concentrate the attention on those side effects more stronger, with a higher impact on quality of life of our patients, the so-called grade 3 adverse event, we had diarrhea, hypertension, QT prolongation, fatigue. All these side effects can be somehow managed, either with other drugs, for example, for hypertension, or by reducing the daily dose of the drug. But indeed, a certain impact on the quality of life of our patient is present during this treatment. These are the adverse events of cabozantinib. If you look at the type of adverse event, are more or less the same that we already described for Vandetanib. What is different is the prevalence. And with cabozantinib, the most prevalent and the most severe are diarrhea and the hand-foot skin reaction. What we learn over the years is that very likely, these adverse events are due to the strong activity of both Vandetanib and cabozantinib against the vascular endothelial growth factor receptor. If you look at the EC50 that represent the alpha maximal inhibitory concentration able to block the receptor, you can see, for example, in Vandetanib that it is 130 for RET and 110 for and 40 for VEGFR. So what that means that we need a much lower amount of drug to have and having a bigger effect on the vascular endothelial growth factor receptor respect to RET. And this is also true, as you can see here, for cabozantinib. So the idea is that these adverse events are due mainly to the strong activity against the vascular endothelial vascular receptor. Thus, the idea that was developed after these evidences is that tumors with an altered RET oncogene should be treated with specific anti-RET drugs. And in fact, nowadays, we have a second generation of tyrosine kinase inhibitors, like Selpercatinib and Pralsetinib, which are really, as I will show you now, very selective for RET oncogene. And you can see here in this table the EC50 of the different drugs here on your left against the different mutation of RET and against the vascular endothelial growth factor receptor. If you concentrate your attention on Selpercatinib and Pralsetinib, you can see that the EC50 is very low for different type of RET alteration, but at the same time is very high against vascular endothelial growth factor receptor, which means at the variance to the other tyrosine kinase, to the multi-kinase inhibitors, that a low daily dose of the drug is able to block the RET, but not the vascular endothelial growth factor receptor. And these are the first initial in vitro and in vivo studies showing that Selpercatinib is a strong inhibitor of different type of RET alteration. You can see here in this part of the slide that were treated different tumor models induced by different RET alteration, even fusions or point mutations, here reported in the middle of the slides. And you can see they were treated with cabozantinib and separately with Selpercatinib. LOXO 292 is Selpercatinib, and you can see that Selpercatinib reduced the tumor size in all different type of induced tumors. And on your right, you have an experiment, the results of an experiment performed in orthotopic brain model, in which the tumor was induced by a RET fusion, and you can see that cases treated with LOXO, here in blue, had a much longer survival respect to those treated with another multi-kinase inhibitors, ponatinib, or not treated or untreated. Thus, after this initial in vivo and in mouse experiment, a big, huge trial, phase 1/phase 2 trial was started, enrolling all human tumors characterized by the presence of RET alterations. In particular, we concentrate our attention on the group of RET mutant medullary thyroid cancer. As you can see, they enrolled more than 350 patients. Some of them were previously treated with Cabo, Vandetanib, or both, while another group was completely naive. The primary endpoint was the objective response, and then, of course, the duration of response and the progression-free survival. First of all, as you can see here in these waterfalls, in which each bar represents a target lesion, you can see that the majority of lesions treated with Selpercatinib had a very strong reduction. And using the RECIST criteria, in which partial remission is considered when the shrinkage is bigger than 30%, you can see that 2/3 of cases had a partial remission and the others had a stable disease. The difference between the graphic A and graphic B is that in graphic A are patients who were previously treated with Vandetanib or Cabozantinib or both. And you can see that they had a very good response, very similar to the group of patients reported in graphic B who were naive. I would like also to highlight that in this study, there were also complete remission, 3 in the patients previously treated with other TKI, and 3 also in patients treated naive. The study was, the enrollment was continued, and the results that were demonstrated in the first group of patients previously treated with other drug was confirmed, as you can see here, also when the group was enlarged from 55 to 143 cases. The objective response rate that was 69 in the first analysis was maintained even when the group was doubled, and the same more or less is for all the other analyses, the complete response, partial response. In other words, by increasing the number of treated patients, the results didn't change, they were confirmed. And the same was for those, for the naive. In the first analysis, there were only 88 patients, and then the group was enlarged up to 112, and again, the results were confirmed and were confirmed to be similar in previously treated and previously untreated patients. What about the different type of RET mutations? I didn't tell you that the mutations that can be present in medullary thyroid cancer are several. We can have mutations in the codon 1918, that is the most frequent, but we can have a mutation in codon 804, and also in many others. And there were no differences, no major differences in the response to Selpercatinib according to the different mutation. And this was true for both cases that were previously treated with Cabo or Vandetanib, and in patients who were naive. Here is an example of a case, a 31 years old woman with a metastatic medullary thyroid cancer with a somatic RET mutation N918, who was treated with 2 lines of multikinase inhibitors and who went into progression. As you can see here, a big, huge metastatic lesion in the thorax and a big, huge metastatic lesion in the liver. And this is the same patients, the same lesions after 10 months of treatment with the Selpercatinib. The disease is still there, but the lesions are much smaller. And this is a very peculiar case that we observed, that we had the opportunity to treat. This is a patient, a 53 years old man with a metastatic medullary thyroid cancer with the RET 918 mutation, who also was treated with 2 lines of multikinase inhibitors, who developed a choroidal metastasis and suddenly became lost the sight. And this is the lesions at the choroidal site. You can see here the detachment of the neuroepithelium, the lumpy bumpy surface, and the thickness of the choroidal layer. After the treatment with Selpercatinib, there was a completely restore of the choroidal, with the resorption of the detachment of the neuroepithelium, and the patients started to see again. What about, in general, what about the efficacy of Selpercatinib and respect to the other multikinase inhibitors? We can say that the overall response that was obtained in the Libretto 001, that is the phase 1-2 study, is around, as you can see here, 70% in naive patients, 61% in previously treated. And it became, this percentage arrived to 85–86% regarding the disease control rate. What about the other two drugs? The overall response in Vandetanib can be considered around 45% and 28.5% in Cabozantinib. But the disease control rate at the end of the story is not so different in patients treated with Selpercatinib respect to Vandetanib and Cabozantinib. What about the safety profile? The side effects, the adverse event of Selpercatinib exist. There are several, as you can see here on your left. But if you concentrate your attention in the most severe adverse event, grade 3 and grade 4, you can see that they are very rare, very rare. So if there are side effects, they usually are grade 1, grade 2, that means they are somehow manageable. And which difference we have among side effects of Selpercatinib and those of Vandetanib and Cabozantinib? There are some side effects that are common to the three drugs, and also the prevalence is very similar, like hypertension. Hypertension is about 30% in the three studies using the three different drugs. And the prevalence of hypertension grade 3 is also similar in the three treatment. There are other side effects that are common to the three drugs, but in Selpercatinib have a much lower frequency, such as diarrhea. Diarrhea is present only in 17% of patients treated with Selpercatinib, while is more than 30% in patients, more than 56%, 65% in patients treated with Vandetanib and Cabozantinib. And finally, we have some new, let's say, new adverse event, like dry mouth, that probably is the most common side effects of Selpercatinib, and facial edema. How much this adverse event impacted on the treatment of patients? And they impacted similarly or differently in the patients treated with the three different groups of drugs, three different drugs. Well, if we look at the effect of adverse event in terms of dose reduction rate and discontinuation rate for adverse event, we can observe that for Selpercatinib, we had a 30% of patients who require a dose reduction rate, more or less similarly to Vandetanib, while for Cabozantinib, this prevalence increased up to 76%. Probably the starting dose of Cabozantinib is much less tolerated than the starting dose of Vandetanib and Selpercatinib. And the discontinuation rate is also very important. Only 2% of patients treated with Selpercatinib require to discontinue the drug for adverse event, while 12% and 16% should discontinue the drugs of Vandetanib and Cabozantinib for adverse event. So after these studies, this multicentric study and the results of the study, Selpercatinib, with the commercial name of Retevmo, was approved for all adult patients with metastatic RET fusion positive non-small cell lung cancer, for adult and pediatric patients older than 12 12 years with advanced or metastatic RET mutant medullary thyroid cancer, and adults and pediatric patients older than 12 years of age with advanced or metastatic RET fusion positive thyroid cancer who require systemic therapy and who are radioactive iodine refractory. What about Pralsetinib? Pralsetinib is somehow very similar to Selpercatinib, is rather specific for RET, even if he has some other activities against other receptors, not very strong, but still present. And here are the results of the in vitro study showing the ability, the capacity of Selpercatinib and compared with Vandetanib and Cabozantinib in reducing the growth in cells with mutation, with RET mutation, either point mutation or fusions. And the difference is, of course, very relevant. Here are the results of the ARROW trial that is very similar to the Libretto 001 trial. Is a phase 1, phase 2 trial in which patients with RET alteration were treated. In this figure, you have medullary thyroid cancer patients in light blue and papillary thyroid cancer patients in stronger blue. And you can see that the majority of them had a partial remission according to RECIST, and the others had a stable disease, no progressive disease under Pralsetinib. And what is very interesting, but indeed this is true also for Selpercatinib, also patients with this mutation, V804M, had a very good response to the drug. Why this is important? Because this mutation is a mutation that induces a primary resistance at least to Vandetanib. And this is an example of a patient with this type of a mutation treated with Pralsetinib before and after treatment. You can see the big reduction of the liver drug, the liver lesion. What about adverse event? Also for Pralsetinib, adverse events were primarily grade 1 or 2. They were mainly hematological alterations, and only 4% of patients discontinued the drug for adverse event. And after the ARROW study, Pralsetinib has been approved with the name, with the commercial name of Gavreto, with the same indication as Pralsetinib, as Selpercatinib. The problem is that it is already clear that some mutations inducing resistance to this drug can be developed during the treatment. This is a very nice and interesting study performed mainly on patients with non-small cell lung carcinoma, in which the authors could demonstrate that during the treatment, new mutations, particularly a point mutation of RET at codon 810, will appear during the treatment, and this make resistance to the drug, as showed in the left part of the slide on the bottom. You can see here different cell lines treated with the drug, some with these mutations, and they have a very low response. And what we know nowadays is that the resistance mechanism to Selpercatinib and Pralsetinib can be due not only to the development of new RET mutations, but also to a MET amplifications, to a KRAS activation, to the activation of some microRNAs. So the problem is really the problem of the resistance. At this point, we could think that we are at the end of this story. No, we are not at the end of this story, because other drugs are under development, even more precise than Selpercatinib and Pralsetinib. For example, TPX0046 is a structurally differentiated RET inhibitor that is potent against a range of RET fusions and mutations, including solvent front mutation, which induce Pralsetinib and Selpercatinib resistance, like RET G810. In addition, this drug does not inhibit the vascular endothelial growth factor receptor kinases, which are often associated with cardiovascular toxicity, such as hypertension. And this is an example of what we will have in the future. In the future, we will have a different type of drug. We will have a scheme with the EC50 of each drug for different type of mutation, same oncogene, but different mutation. And according to the mutation present in the tumor of our patients, we could choose the drug which the lowest EC50. So not only a drug specific for RET, but a drug specific for RET mutation. So to conclude, patients with advanced medullary thyroid cancer have a long life expectancy, and many lines of treatment are needed. At the moment, only Vandetanib and cabozantinib are approved for progressive medullary thyroid cancer as a first and second line, no matter the presence of a RET mutation. Selpercatinib and Pralsetinib are producing a revolution in medullary thyroid cancer treatment thanks to their low toxicity profile and efficacy, but they are usable only in RET-positive cases. At the present, Selpercatinib and Pralsetinib are approved only for progressive medullary thyroid cancer as a second line, and other studies are warranted to find new drugs for the treatment of cases resistant to Selpercatinib and Pralsetinib, and this is very important, for RET-negative medullary thyroid cancer patients that still represent around 20% of medullary thyroid cancer. Thank you very much for your attention.
Rossella, thank you very much. That was truly an outstanding lecture, incredibly informative and incredibly comprehensive. I see that we are joined this morning by Dr. Brito, and welcome, JP. I have a number of questions that I would like to pose here. The first is really on a basic, more basic level. In terms of, you started with a discussion about the extent of thyroidectomy, and it appears that you are advocating a total thyroidectomy in virtually all medullary thyroid cancer patients. There is some controversy across different guidelines, including the Japanese, with respect to for smaller medullary thyroid cancers. Do you advocate, or the guidelines in Italy recommend total thyroidectomy for all patients?
Thank you for these questions, because this is a real new field. So far, at least American, European, and Italian guidelines for the treatment of medullary thyroid cancer suggested to perform total thyroidectomy and central neck dissection in all cases. Central neck dissection, even small cases. Central neck dissection can be avoided if the levels of serum calcitonin is lower than 40, 50 picogram per milliliter. But still, let's say, until now, the idea is that total thyroidectomy should be performed. Indeed, in the last years, there is some thought about about the possibility to reduce the thyroidectomy to an hemithyroidectomy whenever the nodule is small. There is no other nodules in the other lobe, and there are no lymph node visible, detectable at neck ultrasound. Japanese, as usually, started as first with this, let's say, indication. There are, to my knowledge, there are not yet good prospective studies. Studies are all retrospective. Personally, I am convinced that in some cases we can reduce the thyroidectomy to lobectomy, but again, we still have a 15% of sporadic medullary thyroid cancer that are multicentric. So, I mean, I am open to the idea to reduce the extension of thyroidectomy to lobectomy in some cases, but we have to have a very good neck ultrasound before performing surgery. And also we have to take into account that at least 15% of cases can be multicentric. It's a little bit the story of small papillary thyroid cancer.
Okay. Can I ask one more question here before I open up the two other questions from JP here? So in RET-positive medullary thyroid cancers, how do you make that decision about where to start with therapy for those patients who are deemed to be candidates for systemic treatment? Do you start with specific RET inhibitors? Do you start with multi-kinase inhibitors? How do you think about this, and what's your approach?
In clinical practice, at least in Italy, we cannot start with Selpercatinib or Prasetinib as first line. We are running a phase 3 clinical trials in which naive patients can be enrolled, but they are randomized in two arms, Selpercatinib arm or an arm in which they are treated with the standard of therapy. That means Vandetanib or Cabozantinib. So this is for patients who can be enrolled in clinical trials. While in clinical practice, we can only start with either Vandetanib or Cabozantinib. The choice is related to the let's say, type of patients that we have in front of us and the type of lesions that the patients have. If we need to reduce very quickly the lesions, because maybe, for such an example, there is a lesion in a vertebra that can push, compromise the midollo, the bone marrow, we can start with the Cabozantinib, because Cabozantinib is very strong antivascular agent, and the lesions shrink very, very rapidly. But for example, if we have a patient with infiltration of the trachea or of a bronchus, Cabozantinib is too strong, and Vandetanib should be preferred, because the activity of Vandetanib is good, but is lower than the activity of Cabozantinib. And then there are also other reasons. For example, Vandetanib has the problem of the QT elongation. So if the patient has already a QT elongation himself or herself for their own reasons, maybe it's preferred to use cabozantinib than vandetanib. So there are many reasons, many, let's say, things that have to be considered before starting the drug. We generally do this in a multidisciplinary team, and we try to choose the drug that we think is the best for our patient.
Great. JP, do you have a burning question you'd like to ask at this time?
Yeah, just a brief one. And again, hi, Mark, and thank you, Dr. Elisei. Fantastic presentation. Just we are actually facing a very typical question on what to do with a patient with medullary thyroid cancer, and the idea of somatostatin analogs had been brought up with the principle that sometimes in the ultra scan, you can see some uptake of these tumors and whether we should treat them with the somatostatin analogs. Have you had any experience or any perspective about the future of these peptide-based treatments with radionuclides?
Well, this is something that was used in the past and is still something that is currently under, let's say, observation. Unfortunately, there are no strong data. There are not positive, strong data. And chatting with our nuclear medicine, they feel that patients are treated too late with this type of therapy. Probably we should start earlier, because when the lesions became too big, it's more difficult for the drug to destroy or the lesions, because they remain on the surface of the lesions. In any case, I think that is a type of therapy that must be considered, especially for cases that are not mutated for RET, for cases that became resistant to the other drugs. So it's a kind of therapy that should be maintained in the let's say, in the basket of therapies that we can choose for our patients.
Thank you.
Rossella, we have a question from the audience, Dr. Villa. His question is that you've made a very strong case for selpercatinib and pralsetinib as first-line treatment for metastatic medullary, with better efficacy and a better scheme of adverse events and more specific RET inhibition. And so his question is this ready for incorporation into the guidelines in general implementation? And in addition to that, in non-responsive patients, is there a role for cabozantinib and vandetanib as a trial for second line? And would you expect efficacy in an individual patient who failed more specific RET inhibitors, selpercatinib or pralsetinib?
Okay, a lot of questions in a single question, but I will try to answer. Okay, I think that we have to start to consider pralsetinib and selpercatinib in the guidelines. The problem is that they are not yet approved as a first line, but they are approved as a second line. So at least we have to include them and let people know that they exist. Moreover, as I said, there is a trial ongoing for selpercatinib, and very soon another one will start for pralsetinib, in which we are comparing both the efficacy and the safety of selpercatinib against cabo and vandetanib. Thus, the results of these two trials, I don't know when we will get these results, probably we need a couple of years. But at the end of the trials, the results should tell us if Selpercatinib and Pralsetinib can be used as a first line because maybe they have the same efficacy or even stronger, but a better safety profile. Then I don't remember which other question he asked.
So one of his questions relates to whether or not RET inhibitors have an impact on other clinical aspects of MEN2, such as pheochromocytoma, parathyroid, cutaneous manifestations. Do you have any information regarding those?
Okay, yes, I can tell you something about pheochromocytoma and Vandetanib and cabozantinib. Actually, pheochromocytoma respond to the drug in terms that they do not grow anymore. They reduce the amount of methanephrine produced. And I don't have experience yet with Selpercatinib because we didn't treat MEN2. There was no opportunity to treat MEN2 with the Selpercatinib, but for sure, pheochromocytoma respond to Vandetanib and cabozantinib. Parathyroid tumors are very rare, actually, and cutaneous lichen amyloidosis. I saw some of these lesions, but probably in patients who did not require to be treated with these drugs.
Great. Could you comment on any role for these drugs in a neoadjuvant setting for patients with advanced local disease in an effort to try to get reduction prior to surgery?
Okay. There are no studies, but there are, let's say, clinical experience. In our clinic, we treated few cases with either Vandetanib or cabozantinib, and what we got is the stop of growing of the disease. But the problem is that when these patients are not cannot be treated by surgery, in general is because there is infiltration of the trachea or esophagus or some other things. So what we can obtain as with an adjuvant therapy is the stop of growing or even the reduction of the size of the lesion. But if there is infiltration remain. And at least in our cases, we were unable to surgically treat the patients. I don't know if I explain myself. In other words, we can use the drug to reduce the growth of the disease, but if we think at an adjuvant therapy in terms of after this therapy, we will be able to operate patients. In our experience, this is not the case.
Great. One last question I have related to the exam trial with cabozantinib. There was a 6% fatality rate in that trial. Are there any common clues as to why those particular patients, and are there ways to avoid that, or is that a patient selection? Do you have any insights into that particular issue?
Yeah, the fatal cases were mainly due to gastrointestinal hemorrhages. And nowadays, again, when we choose the drug to starting with, one thing that we look at are the aspect of the gut. I mean, if the patient has diverticulitis, it is better do not start with the cabozantinib. Or at least if we have to start with cabozantinib, it is better to start with a lower daily dose respect to the dose indicated by the drug itself.
Great.
So,
Pete, do you have any last minute question or anything to that you'd like to round up with? JP?
I'm sorry. No, I think it was a great presentation. Thank you. No more questions.
Great. Rossella, I can't thank you enough. We're up against the end of the hour here and have to sign off. Thank you so much for your efforts and for carving out the time. And thank everybody for joining us. We will be back next week with another lecture by Dr. Hung, and look forward to everybody joining us. Thank you all, and everybody stay safe. Thanks once again, Rossella.
thank you very much. It was a pleasure.
Thank you. Bye-bye now.